This has been heartbreaking every day. 226 deaths, 226 families, and you see how that number has been infuriatingly constant. 226 is where we were 5 days ago. We had thought initially, and again, so many of what the initial information we had turned out not to be correct or turned out to be modified. But we were laboring under the impression that young people were not affected by COVID-19. And that was actually good news, right? The vulnerable populations were older people, people with comorbidities. But one of the few rays of good news was young people weren't affected. We're not so sure that that is the fact anymore. Toddler, elementary school children are presenting symptoms similar to Kawasaki disease or toxic shock-like syndrome. Now, these are children who come in who don't present the symptoms that we normally are familiar with COVID. It's not a respiratory illness. They're not in respiratory distress. And I think that's one of the reasons why this may be getting discovered this far into the process. It's more an inflammation of the blood vessels, which can then cause problems with their heart. And there are 73 cases that the Department of Health, Dr. Zucker, is now studying. But the illness has taken the lives of 3 young New Yorkers. So this is new, and it's developing. The Department of Health has communicated with the federal officials, the CDC, and the CDC has asked New York to develop national criteria for this so that other states, other hospital systems can also be checking into this and looking into this. Again, as it turns out, these children happen to have the COVID antibodies or be positive for COVID, but those were not the symptoms they showed when they came in to the hospital system. So it's still very much a situation that is developing, but it is a serious situation. The Department of Health is also going to be working with the New York Genome Center and Rockefeller University to conduct a genome and RNA sequencing study to see if there's something about these children that may present a definable situation. But rest assured, the Department of Health is on top of it. This is the last thing that we need at this time with all that's going on, with all the anxiety we have. Now, for parents to have to worry about whether or not their youngster was infected. And again, symptoms that don't even seem like the symptoms we associate with COVID-19. So we still have a lot to learn about this virus. And every day is another eye-opening situation. But rest assured, the Department of Health is doing everything that they can do. I think it's fair to say that the New York State Department of Health is the first one that has been a priority that we've been working on throughout, has been protecting our frontline workers. We're very aware of the sacrifices that our frontline workers are making, so many of us can stay home and stay safe. And we want to make sure we're doing everything we can to protect our frontline workers. We've been working with the healthcare workers, police officers, firefighters, EMT, and our transit workers. In New York, we have to keep the public transit system operating. That's how many essential workers, frontline workers, get to work. If we got to a situation where we had to close down public transit, our hospital system would have suffered. That's how nurses get there. That's how the hospital staff gets there. But our transit workers had to operate that transit system right in the midst of this COVID virus, and it never stopped. Bus operators, train operators, the station cleaners. So while everyone was trying to get home, trying to stay safe, they were showing up for work every day to make sure that the people who did need to go to work could get to work. We've already conducted the largest antibody test in the country, 15,000 people in that sample. What the antibody test tells you is who has been infected by the virus and then has the antibodies as they recover. And that gives us a baseline, that 15,000 survey statewide, to compare other groups against. So we know what the average infection rate is in different parts of the state. We can then compare groups to that baseline. We recently tested the transit workers writ large who have been doing the operations of the transit system. We tested 1,300, so that's a large size sample. 14% was the infection rate among transit workers, and that's actually good news. We'd like to see 0, but 14% is below the average infection rate for New Yorkers. So it means that the transit workers' infection rate is below the norm for New York City. Within the transit workers, it's a little higher with station workers than with bus operators or train conductors, assistant conductors. But all categories are below the New York City norm. The New York City norm was 19.9. So that is good news. And that also affirms the news we've heard on the other essential workers, frontline workers. Our healthcare workers, nurses, doctors, we were afraid that because they were literally in the emergency rooms, they'd have a higher infection rate. But it turns out that's not true. 12% was the infection rate among those workers. It shows that the PPE works when we talk about masks and gloves, et cetera. It's not that nurses and doctors in those emergency rooms have fancier equipment, a more sophisticated equipment. This is the same type of mask that they wear, so it works. New York Police Department had an infection rate of 10%. Fire Department and EMT had an infection rate of 17%, which is the highest of all those groups. We think it's higher because of the EMT workers, but again, all below the New York City rate of 19.9. Another issue that we've been aware of and we're working on is the fact that poor and minority communities are suffering most. The numbers in this state are not nearly as bad as the disparity in many other states, but any disparity is bad, and that's what we have been focusing on here. We did surveys and data that show if you look at the 21 zip codes with the highest number of hospitalizations for COVID, 20 of those 21 have greater than average African American or Latino populations. 20 of 21 of those zip codes. So there's no doubt that it is a problem, and we've mapped this, and you can see exactly where people are coming from as they're walking into hospitals. Part of the new system that we've implemented through this is hospitals report nightly how many cases they have, where they come from, and we can now literally map the number of people and where they're coming from throughout the state. And then when you look into that information, especially in Brooklyn and the Bronx, it's clear that the communities are heavier minority population and heavier low-income population. And when you compare that with the overall city rate, it makes the same point. That hospitalization rate, infection rate among the minority community, among lower income communities, is higher than the average. Unfortunately, in a cruel irony, this is often the case. When you look at disasters, emergencies, I don't care if they're hurricanes, floods, whatever they are, cruel irony is the poorest people pay the highest price. I've seen this across the country when I was at HUD. You're there to take care of a flood or a storm. It's the poorer communities that get wiped out first, right? It's the lowland. It's the land that tends to flood, that it has the lower value. And that's where the lower income community tends to locate. So we understand why, we understand the health disparities, we understand comorbidities, but we also understand it's just not right. It is just not right. And we have to address it. We saw the same thing in Hurricane Katrina. Those people who were on rooftops were not the wealthy white part of the community. They were predominantly minority. They were predominantly low income. Those rooftops very often were public housing. So this has been the pattern. Flint, Michigan, the people who were drinking water that was poisoned, they were low-income minority populations. If you even go back to 1927, the Great Mississippi Flood, where does the Mississippi flood? It floods the lowlands. It floods lower-income communities. We get it, but we have to break the cycle. New York, we're going right at finding the reasons for the disparity and resolving them. We are doing more testing in low-income communities and communities of color. We're doing testing in public housing aggressively, excuse me, partnering with Ready Responders, which is a group which is doing great work. We've delivered PPE equipment, masks, over 1 million, hand sanitizer, et cetera, to public housing. And today we're launching a new initiative, again, to address exactly this, which is to expand access to testing in low-income communities and communities of color. We're partnering with Northwell Health, which is the largest health system in New York, and they're going to set up 22 additional testing sites at churches in predominantly minority communities. This is a different kind of partnership. It's creative, but it's necessary. We're working with both churches individually and association of churches and Northwell. Northwell will provide the testing in churches in lower income communities and communities of color. The churches will help us outreach to the community to get people to come in and explain why it's important that people come in and get tested. And Northwell will do the testing. We have 24 sites in the New York City area. Some will be opening the week of May 12th. Some will be opening the second week of May 19th. But you see the coverage when we add the network of churches is very broad, again, focused on these communities that we want to reach out to. These 24 new sites will be working with the current network of sites, and we've already located many testing sites in minority communities and low-income communities. But when you put the church-based sites together with the drive-through sites, together with the walk-in testing sites, and our sites at public housing, the coverage will be extensive. So the sites will be there. We now need New Yorkers to go get the tests. And I know, I do this with people all day long. I feel fine, I feel fine. You can feel fine and test positive for COVID. You can. You can be asymptomatic and still have the COVID virus. Well, if I feel fine, what's the difference? Because you can give it to someone else who will not feel fine. And you can give it to a person who's more in a vulnerable community group, older person, person with an underlying illness, and they could be in serious trouble. So you want to know if you have it, not just for yourself, but so you don't communicate it to anyone else. I want to thank our partners who are been working on this. It's exactly what we want to do. All through this situation, we said we don't want to just deal with this virus. We don't want to just replace what was there. We actually want to make sure that we build back better than before. I understand that this inequity, this disparity exists. I understand it's existed for decades. I understand it exists all across the country. but not New York. Not New York. It shouldn't be here.